Okay. Hi everyone, this is Mackenzie, and this is the panapto for our case study of HHNS, also known as hyperglycemic hyperosmolar non-ketotic syndrome. So let's start off with our case study. So let's meet the client. Shelley Foster is a 42-year-old Caucasian woman, type 2 diabetic with a BMI of 35 or a weight of 92 kilograms, who was transferred to the emergency room with an altered mental state and elevated blood glucose levels. When she arrived at the ER, her blood glucose levels were 70.2 millimoles per liter. Shelley's husband, Rodney, reported that she had had a 1-week history of flu-like symptoms, as well as nausea and hematemesis. Moreover, she had not taken her insulin for over 1 year, which is used to control fluctuations in her glucose levels, and she had stopped taking her metformin, which is also used for glucose levels. After having lots of fights over the issue with Rodney, she had restarted her metformin a few days prior to this episode, which may have induced her nausea and vomiting. Also, her abdominal CT scan showed suggestive pancreatitis, which is the inflammation of the pancreas. A quick look at her past medical history. She has type 2 diabetes for 10 years, chronic back pain for 15, hypothyroidism for 3, hypertriglyceridemia for 12, bipolar for 15, asthma for 6, and she smokes 1 pack of cigarettes per day, and that's Shelley over there. And then the current medications that she's on are oxycodone, Humulin R, rosuvastatin, olanzapine, metformin, levothyroxine, lithium, and an albuterol inhaler. So when she's in the ER, we take her vital signs, and her temperature is at 37.9, which is pretty high. Her pulse is at 110 beats per minute, and her respiratory rate's at 22 breaths per minute. And her labored BP is 110/50, which isn't like that low, but it's not really like the normal, so we're still pretty worried about it. In her patient assessment, her neuro assessment shows that she's unresponsive times 3, and her Glasgow Coma scale is 10, and lower than 7 is like coma state, so she's getting pretty close, which is pretty worrisome for us. Her HENT showed a dry, parched mouth. She has warm, dry skin, and tachycardia is present. So her lab values, her sodium is high at 160. So this is high because she's most likely dehydrated, which is very common in HHNS, so that's to be expected. Bun and creatinine, these are high because these are like measuring the levels of her kidneys. So kidneys, when with regards to glucose, kidneys reabsorb glucose, and so when there's too much glucose to be reabsorbed, the kidneys are working overtime to try to reabsorb that glucose. So they're working extra hard, which explains why both those levels are high. Her glucose level's high, but that's because she came in. And then with high glucose levels, CK, that has to do with the liver, and so if she's maybe drinking or if she's taking certain medications that are hard on her liver, that can make her CK levels go up a little bit higher, a lot higher in this case. Amylase and lipase, those are in relation to the pancreas. So her pancreas is inflamed right now, so obviously these levels are going to be extremely high. Yeah, and she has triglyceridemia, so that also has to do with the liver. So that makes those levels even higher. And then she's got a low pH at 7.3, so she's in acidosis. Her hematocrit is high, but that's expected in dehydration. Her TSH levels are high, so your levels of TSH are going to be high when you're not making enough thyroid hormones, which is why her T4 level is low, because she's not making enough thyroid hormone. And so, yeah, I guess there's not really much else to say about that. I just tried to explain it to the best I could. Probably didn't need my help, but just so you know. Her ER visit continued. She had aggressive fluid resuscitation, and aggressive treatment is needed in HHNS because it's like an extreme complication. So, along with boluses of normal saline and Humulin R insulin drip, she was then admitted to intensive care because her blood pressure had dropped to 91/54, which is very, very concerning, and her respiratory rate escalated to 42, requiring intubation and vasopressors. So, a week into her hospitalization, her blood pressure was positive for staphylococcus, which is an infection with symptoms of systemic inflammatory response. So she was prescribed IV vancomycin every 8 to 12 hours, 20 milligrams per kilogram per dose. And she recovered from her HHNS and various coexisting illnesses and was discharged home in stable condition on her previous medications. And so, 1 month visit. So after 1 month of her being discharged, our team decided to take a home visit to Shelly and Rodney. Shelly expressed that she'd been stressed about losing her job as an administrative assistant at Home Depot. Rodney was busy working 2 jobs to cover their living expenses, and we see cases of empty beer bottles, and Shelly is well aware of her surroundings. She slurs her speech a bit and seems slightly unsteady on her feet, although she says that some of her medicines give her the shakes. So continued, we check her vital signs, and her temperature it's not high, but it's really like borderline high, like the very highest it can go to be in normal range, so that's a little bit concerning. Her pulse is really high at 115. Respiratory rate is also borderline at 18, but she has asthma, so maybe that is a reasoning for that. And her blood pressure is 126 over 86, and I'm not really concerned about that. And her blood sugar levels have reduced a hell of a lot to 17.2. And Shelly confesses to you that she's been drinking more beer lately, and she hasn't filled her insulin or metformin prescription as it costs her enough to fill her prescriptions for her cholesterol, her bipolar, hypothyroidism, and her chronic back pain. She says that she doesn't like her metformin anyways, and that she would like to try some complementary therapies and medicines, straighten her blood sugars naturally, because her friend Shirley has told her that they work as cures and miracles. She says that she wants to know more about massage therapy, acupuncture, fenugreek, bitter lemon, and neem leaves for lowering her blood sugar instead of taking metformin, and she wants to see if she can get the government to pay those for her. She says she doesn't enjoy exercise, and she isn't interested in major diet change as she likes her beers to relax. So now on to the pathophysiology of hyperosmolar hyperglycemic non-ketotic syndrome. So these are just some terms to know. Just so like when you guys are going over this and studying it, you can refer back to this. Shout out Emily for doing this in her presentation because she inspired me to do it in mine, and it's super helpful. Like when I was going over heart failure, this was super helpful, and I was glad she made it because I really needed a reminder throughout her presentation. So really briefly, I'm going to explain hyperglycemia. Just a fancy word for high blood pressure, honestly, or what the heck am I talking about? High blood sugars, sorry. And this can occur for many reasons, like what you eat, how much physical activity you do, an illness, adverse effects of other drugs or medicines that you're taking, and just simply not taking your glucose level lowering medication in the first place. Some symptoms of this include increased thirst, blurred vision, higher urine output, fatigue, and headache. And this strongly affects people with diabetes mellitus. So hyperglycemia is like the number one thing that you think about when you think about diabetes. So what is diabetes? It's a chronic disease where the body either A, cannot produce insulin, which is a hormone synthesized in the pancreas by beta cells to control blood glucose levels, or B, it just can't properly use the insulin that it creates, so it's insulin deficient. So when blood glucose levels are too high, insulin is released. It takes in sugar to use as energy, or it stores it as fat, and this will cause your blood glucose levels to go back down to normal, and then it's restored. So in the case of diabetes, like your body can't use insulin, so it can't take in the sugar to use as energy or store it as fat. It's just free floating in your plasma. And there's 2 types of diabetes. There's type 1 and type 2. So in type 1 diabetes, this occurs when the immune system mistakenly attacks and kills beta cells in the pancreas. So no or very little insulin are released into the rest of the body, and sugar builds up in your blood. Generally, this develops in children or adolescents, but it can develop in adulthood. But this is more of the type of diabetes you'll see kids have, or like teenagers have, or even young adults. And it's treated with insulin, and meal planning is really key with this one because you want to make sure you're not eating too much sugar or too little sugar. Type 2 diabetes is when the body cannot properly use the insulin that's released into the body, also known as insulin insensitivity, or it just doesn't make enough insulin in the first place. So 90% of people with diabetes have type 2, and it's more commonly seen in adults. Older people with BMIs greater than 25. So depending on the severity of the type 2 diabetes that you have, some people are able to use physical activity and meal planning to treat their diabetes, and just like that's amazing to me because like if you could just treat every illness with physical activity and meal planning, life would be a freaking breeze for some people. But since there are more serious cases that don't just work with physical activity and meal planning, medications such as insulin and or metformin may be introduced into your lifestyle to control your blood glucose more effectively. This is just a little picture that shows how like genes and the environment can really affect your like if someone develops diabetes or hyperglycemia. So like the environment includes like a virus you might have, how much physical activity you do, or what you eat. So if you go to the left, that's more of type 1 diabetes, and to the right is more type 2 diabetes. So in type 1 you have beta cell destruction, and in type 2 you've got beta cell dysfunction. Both lead to hyperglycemia, and both can lead to diabetes, type 1, type 2, or other forms, which lead to complications. Other forms of diabetes include gestational diabetes, which is just temporary diabetes you get during pregnancy, or there's prediabetes, which is when your blood glucose is high but not high enough to have diabetes, so it's like right before diabetes. And then there's different types of complications. There's microvascular complications and macrovascular complications. So in microvascular, there's like retinopathy in your eye, nephropathy, and neuropathy. And then macrovascular complications, there's coronary artery disease, peripheral artery disease, and stroke, so more of the cardiovascular stuff. So what the heck does type 2 diabetes have to do with hyperosmolar hyperglycemic non-ketonic syndrome? It's a HHNS, a life-threatening complication brought about by diabetes. In type 2 diabetes, HHNS is characterized by two primary signs, which is severe hyperglycemia and severe serum hyperosmolality. So when your blood glucose is greater than 33.3 millimoles per liter, and we know that Shelly came in with 70.2, so she has severe hyperglycemia. And we didn't actually get her serum hyperosmolality in the case study, so we don't know what it is, but we're assuming it's higher than that because she was diagnosed with HHNS. So in the serum hyperosmolality test, there will be no evidence of ketosis in the test, but you can refer back to my terms to know to learn more about ketosis if you'd like. But insulin will still be present in the test. Like there's not no insulin, but there's like just a little bit, just enough. So what is HHNS? It's severe hyperglycemia caused by non-effective glycemic control. So your blood glucose is like out of your control. I just explained this, but serum osmolality, this causes water to be pulled out of the cells, which can lead the cells to shrivel up and become dehydrated. And so not only water is getting pushed out of the cells, but also all your glucose in that cell is getting pushed out, and all your electrolytes in that cell are getting pushed out. So this causes them to go to the blood, and then the concentration of this glucose and of these electrolytes just get higher and higher. If you're confused about osmolality like I was, you can always refer back to the introduction to the endocrine system that we did in class the other day. But the way I think of osmolality is that it refers to the concentration of dissolved particles of chemicals and minerals in your blood, like sodium or potassium and other electrolytes in your blood. So the higher the osmolality means there's more the particles in your blood are more concentrated, and the lower means they're more diluted. So I know that that gets really confusing to me, so just refer back to the presentation or just use what I just used if you can. I don't know. So HHNS is typically onset after a precipitating event such as an infection like her staphylococcus, volume depletion, or trauma, and it can also be onset from alcohol abuse, which was we don't know if she was drinking prior to her admission to the ER, but she might have been, seeing as we found beer in her house when we went to visit after 1 month. And so we don't know if that was happening beforehand or not, so we have to take that under consideration. Any recent operations she had, and the adverse effects of drugs. So drugs that I found that have adverse effects that can cause HHNS were more glucocorticoids and thiazide diuretics, and she's on neither. So this is a picture of the pathophysiology, I guess, of hyperosmolar hyperglycemic non-ketonic syndrome. So Just over to the left is the hyperglycemic part, in the middle is the hyperosmolar part, and to the right is the non-ketotic part. And one thing I just wanted to outline in here was if you go to where it says insulin deficiency, there's an arrow that goes all the way over to ketogenesis. So the fact that there's still insulin in the plasma inhibits ketogenesis, which is why there's no ketones when it comes to HHNS. And then at the bottom is all the symptoms there, but in the next slide I'm going to go over those a little more. So signs and symptoms of HHNS in comparison to DKA, which is diabetic ketoacidosis, which I will explain in a few more slides, which develops in just a few days. HHNS can take up to days or even weeks to fully develop, so it takes a little longer. You'll see higher blood glucose, like extreme hyperglycemia when you have HHNS. You'll see extreme thirst and dehydration. You'll see dry, parched mouth. And as hyperglycemia progresses, neurological symptoms such as weakness, lethargy, altered alertness, and confusion will present themselves, just like Shelly had. And you'll also see elevated temperature or a fever and warm, dry skin, which she also had. So the treatment for HHNS is super aggressive. Like, you have to do it hard and you have to do it right away. It involves fluid replacement, insulin therapy, correction of electrolyte imbalances, and management of comorbidities. That's what I found for the gold standard treatment of HHNS. And it remains debatable if 0.9% or 0.545% saline should be infused intravenously, but what I read from the most recent research I could find is that most doctors, since there's not a lot of research on it, will start at 0.9% saline and then go down to 0.5 or 0.45. So this isn't really like necessary, like I wasn't asked to talk about it, but this is just a study I found from like 2013 or 2015. So like not very recent, but like there's not very much research on HHNS, so it was one of the more recent studies that I found. And it was a study of 911 people studied over 12 months. And it really just went into detail about how people with HHNS are so commonly misdiagnosed with like DKA or type 1 diabetes, which is really unfortunate because HHNS, as I mentioned before, is very life-threatening. And so the wrong diagnosis can lead to like longer stay times in the hospital, being readmitted, or being mistreated with like the wrong drugs and everything. So they found that a lot of people in the studies met the criteria for type 1 diabetes with diabetic ketoacidosis, and therefore they were misclassified. And shockingly, only 9 out of 911 people, or 5% of the study, were correctly diagnosed with type 2 diabetes and hyperosmolar hyperglycemic non-ketotic syndrome, and like only that 5% were correctly treated. The people who were misdiagnosed and actually had HHNS and not DKA were also mistreated and eventually were readmitted and had longer stays in the hospital because people were treating them wrong, which sucks. The difference between HHNS and DKA, DKA is associated with 3 major indicators. It's just the ones in like the last 3, not seen more in type 1. So I just wanted to just point out that DKA is seen more in type 1, HHNS is type 2. But DKA is associated with hyperglycemia, hyperketonemia, so that means there's lots of ketones in this case, and metabolic acidosis. HHNS is seen more in type 2. It's associated with severe hyperglycemia, and there's no or little ketones present. So it's really just those ketones, but it's very easy to distinguish the two because HHNS, non-ketotic, and then DKA, diabetic ketoacidosis, there's ketones. So that's not that hard. And this is a little diagram to help with regards to the diagnosis between DKA and HHNS, so we don't keep misdiagnosing people. So it all starts with hyperglycemia to start, and then that's when you'll do an A1C test, and someone with a test score higher than 6.5 is diagnosed with diabetes. Then it just really depends on peptides, like positive or negative peptides, C-peptides, sorry, and you can refer back to my terms note for A1C and C-peptides. And then positive C-peptides means type 2, and then negative or no C-peptides means type 1. And then type 1 is usually, it just leads you to what you should see to be able to diagnose, the lab values you should get to diagnose someone with type 1 or type 2. And then usually DKA is with type 1 and HHNS is with type 2. So how do Shelly's comorbidities make it hard for her to manage her diabetes? So some of her comorbidities include chronic back pain, hypothyroidism, hypertriglyceridemia, and bipolar. So her chronic back pain, like I know that when I'm in pain, I barely like even want to like get up and move or even eat anything. So I can't even imagine being in Shelly's position and experiencing chronic back pain and wanting to take medication. Like it must be so hard for her, and pain can easily discourage someone to perform day-to-day tasks, let alone manage their diabetes. So that's gonna like that's gonna make it very difficult for her to manage her diabetes. So then her hypothyroidism. So hypothyroidism is really just the slowing of your metabolic rate. So this can make it very hard for Shelly to lose weight on top of her diabetes, and this can be very discouraging to her, and it can affect her ability to treat her diabetes. And like when you develop diabetes, like I don't know, you already like we don't know if she's like changed her diet. And like when we visited her 1 month after discharging her, she said she's not interested in diet changes, so maybe she hasn't really changed her diet, and this is not helping with her hypothyroidism. Hypertriglyceridemia. This is very common in type 2 diabetes patients due to enhanced LDL production, which is why she's on the statin. And this can be very hard on her liver. And like, one sec, sorry. Well, like just having having a high production of LDL can be very hard to like manage your diabetes because it's already so hard on your liver. And then bipolar disorder, there's many different ways and theories of how this is caused. Like there's like genetics, neurobiological factors, psychological factors, environmental factors. Like there's not really like there's a lot of different theories of how this is caused, and this can make it difficult for Shelly to remember to even take her medication for her diabetes in the first place. So like I don't know if she's having a bad day or an off day. Maybe she just doesn't want to take her diabetes and she refuses to take her meds that day. And then, sorry, one thing that stumped me so much in this case study was her hematemesis. So it's unclear to why this happened, but according to my research, it could be due to the following, like pancreatitis, a peptic ulcer, or acute liver failure or cirrhosis. When it comes to liver failure and cirrhosis, there's really just not enough evidence that she even drinks enough to like cause like cirrhosis or liver failure, which can lead to her hematemesis. Like we don't know how much she drinks. Like we don't know when she drank all those bottles of beers, but like I guess this is possible with her hypertriglyceridemia because her liver is already working extra hard, but it's highly doubtful. Like we truly don't believe that that's the reason why. Then there's peptic ulcers, and we know that peptic ulcers are more common with people who take NSAIDs, but Shelly doesn't take any NSAIDs, so I don't think it's that. And like alcohol consumption can increase the risk of peptic ulcers, but only if taken with NSAIDs, and she's not taking NSAIDs, so I don't think that's the case. And so I really do believe that is pancreatitis. I read in my research that pancreatitis can cause hematemesis, so that's what I'm going with. Her pancreatitis caused her hematemesis. And then finally, something I wanted to look into was sepsis. So what is it? It's a potentially life-threatening complication brought about by an infection. So she has staphylococcus, so that could lead to it. When does it happen? It occurs when chemicals released into your blood to fight off infection actually trigger inflammation responses throughout the body. So when these are released out into the body and they trigger inflammation instead, this leads to a cascade of changes that can damage your organ systems, which can result in organ failure. So this is like very scary and needs to be acted on very quickly to be prevented. Like it's very scary. Like sepsis scares me. And so if sepsis progresses to septic shock, then this can cause your blood pressure to drop dramatically. So as we noticed, her blood pressure went from being 110/50 to being 91/54. So that's a very big drop in a short amount of time. Like since she was admitted, like they did all those scans and then her blood pressure dropped so dramatically. So that's like a sign of sepsis. And it can also, it's usually seen in older adults who have been exposed to an infection or have a weakened immune system. So she has staphylococcus and her immune system is super weak, and we could tell by her low white blood cell count. And so signs of sepsis include a heart rate greater than 90, and her heart rate was at 110 when she went in, a respiratory rate of greater than 20. So it was at 22, and then it actually escalated like super exponentially to 42. And a low blood pressure, 91/54, is very low. And low urine output, we don't really know about her urine output, but all three of those meet like the criteria for sepsis. And if any of these are present along with a suspected or presenting illness, sepsis is most likely the cause. So, like, I don't even know if the criteria for this project is to like explore, like, I feel like with this project we need to like explore more than like what we were just given in the case study. Like, I was literally just looking through the research, and then sepsis came to like the back of my mind, and I was like, oh my freaking gosh, like what if Shelly has sepsis? So I really felt like I needed to look into sepsis, and I truly believe that she did have sepsis when she went into the hospital. So yeah, that's really all I have to say. So I hope you guys enjoyed this presentation. I know that like sometimes I get really carried away, and like I had that big blank moment in the middle of the presentation with regards to hypertriglyceridemia, but yeah, like the pathophysiology of this is really interesting, and I hope you guys learned like somewhat about HHNS. Like, I'm gonna do a recap in class, but I hope you guys watched this, and I hope you enjoyed it, and I hope it taught you a little bit more about diabetes and HHNS. Anywho, thanks for watching, folks. Oh, how do you get out of here? All right, I'll see you guys in class. Bye.